You've been in practice many years, and you've seen a lot of the TMD treatments, and you've been engaged in a lot of the equilibrations, and you've learned, seen many lectures, seen many cases. You've done a lot of research in regards to TM in your own practice and your experience. What do you make of the immediate complete anterior guidance development protocol to accomplish DTR, ICAGD to accomplish DTR, disclusion time reduction?
I think it excellent. I believe also that we should be looking at the factors that initiate occlusal disease or identify the clinical signs and symptoms that are present. DTR is a component of the entire program with digital occlusal analysis.
So what you're saying, the fact that we can measure something and actually reproduce it and keep a record and
It's
track it over
extremely
time.
important.
Right. Whereas, can you compare for the whoever may be watching what's traditional?
Traditional really is articulating papers, waxes, coating waxes, and foils. Those three, and in particular, probably the least accurate is the use of articulating models.
Yeah. And you say least accurate because?
Least accurate because of inherent problems with expansion, contraction
Of the stone.
Of the stone.
And the impression material.
The multiple portions of the methodology which is involved.
Right.
The Facebook recordings. Also, there are no lateral, or not really accurate for the individual, no lateral recording medium to determine the translation.
The sideways movements
Right.
of the mandible.
Right.
Right. And the Tscan sensor, in your mind, that's invaluable, yes?
Yes.
And does the fact that it has a little bit of thickness to the sensor, does that bother you in any way?
If it were too thick, I think it would. The current thickness is not troublesome to me. Perhaps a more thin sensor would yield better information. Obviously, or in discussing the thicknesses that do produce an alteration in muscular contractility, the muscle contractility will begin somewhere between 20 microns and 100 microns.
Right. And the sensor itself is somewhere in the neighborhood of just under 100 microns thick.
Right.
Yeah, the
So
mild
it's within range of accuracy.
Right.
If it were thinner, that probably would be better.
Yes.
But it might also produce a distension, like for instance, a thin articulating paper
Yes.
is deflected by the cheek or tongue.
Sure. And the thinnest articulating ribbon, we're talking in the 20 micron range.
Right.
Right. That's about the thickest or thinnest they have.
Right.
Yeah.
Right.
And you're looking at ink, which does nothing to track force, nothing to track time. And I think that's key. Don't you agree that the timing is probably the most important thing we get out of the Tscan?
Timing is, although reduction of DTR or disclusion time reduction,
So which
reduction
implies
of DT is deemed extremely important for muscular conditions that are excessive. And from my standpoint, I believe also that the FO recordings, the force outlier recordings, the first point of contact, is also extremely important for having a look at some of the other states of occlusal disease other than TM injuries.
And you're alluding to like parafunction bruxism for force outliers.
Force outliers, I'm really looking at periodontal considerations, where let's say you do have some attachment loss, a tooth is more mobile. Why is it more mobile? Because it's being struck too hard.
First.
Right.
At the wrong
Or
angle.
the timing is wrong.
Yes.
At the beginning.
Yeah.
So you're looking at the pathological sequela of having occlusal errors.
So you wholeheartedly believe that there is a link between timing, force, and periodontal disease?
Yes, of course.
Yeah, I do too.
Yeah.
100%. And that's not mainstream.
No.
Yeah.
No. Periodontal disease, but also the presence of cervical dentin hypersensitivity, CDH,
Yeah.
and the presence of fractions.
Right. Notches in the side
Right,
of the gum line.
that are produced from excessive or chronic occlusal force.
So how would you compare and contrast ICAGD occlusal adjustment to equilibration? Because you've been engaged in equilibration most of your career.
Right. Actually, I probably have been more involved in occlusal adjustment, which is selective occlusal grinding, as opposed to, or occlusal reduction, subtractive therapy, as opposed to equilibration. When I look at ICAGD, I'm thinking more in terms of equilibration,
Right.
adjusting all of the contacts.
But you realize it's extremely different, right?
Yes,
The equilibration increases molar contact, the ICAGD decreases. The equilibration,
equilibration I don't believe implies that you're increasing molar necessarily. Molar contact during excursion.
but you see it's unmeasured. The protocols, they can't measure that. So I can tell you definitively when I do the ICAGD protocol to accomplish DTR on a patient, I'm measuring, and every single time there is more anterior contact, if it's done properly. The center of
Yes.
force icon moves to the anterior,
Right.
and that's part of the fix. That's part of how you'll start seeing in the chair the patient changing and reacting in a
Right.
positive manner.
Again, we're looking at terminology, which is extremely important to have universal understanding of terminology or terminological approach.
Right.
But to me, an occlusal adjustment means selective occlusal grinding. In other words, not adjusting all of the teeth necessarily, whereas with an equilibration, one is. So you can still adjust all of the teeth, let's say for lateral force transmission or DT recordings. One could adjust all of the deflective contacts instead of adjusting just the most severe ones
Right.
that are increasing the time,
Right.
increasing the exclusion time.
Now, the old term dots in the back, lines in the front. We in dentistry have all seen that classic supposed ideal occlusal design. What is your feeling in regards to those lines in the front?
Those really are representing a concept of disclusion time. The lines themselves are the moments of contact or expression of the moments of contact as we're going toward an excursion to the left or right.
Right.
Or
protrusive.
Or protrusive, correct. Oftentimes with a slide that is shown when discussing occlusion, we look at the V, the left lateral, right lateral, as opposed to looking at the straight or sagittal marking that one would go to, and hopefully a non-deflected protrusive.
Right.
But at any rate, there's timing involved in that process of going with your left or right lateral excursion, as shown in the V lines that that one picks up with the articulating paper.
Right. So, in other words, when an individual speaks of immediate anterior guidance, but they're not measuring that, see, that's the difference. Immediate complete anterior guidance development. Immediate, they're timing it, we are, with Tscan. Complete, we're showing that the force is off the posterior teeth in a certain amount of time. Anterior guidance development. Whereas other philosophies, they basically say, let's get onto the anterior teeth, but they say nothing about the timing. The timing, I think, is the single most important aspect of what we're doing with
Quite
digital
agreeably,
occlusal analysis.
quite agreeably. But immediate complete, by its definition, sounds as though you're talking about zero, that you go from
it's impossible.
maximum contact
Right.
to zero, and then that doesn't occur.
Right.
It occurs on a gradation basis. So researchers such as Robert Kerstein, with so much in the way of publications and studies that have appeared, he's indicating that DT to less than 0.4 or 0.5
In that neighborhood.
is physiologic.
Right.
On the other hand, the folks that refer to immediate disclusion as you go to a left or right lateral, they're also not considering time. Who's to say whether 0.1 or 0.2 on the timing value is physiologic or pathologic? The studies that have been done with the Tscan do identify that less than 0.4 or less than 0.5 in that range tend to be physiologic in nature.
Statistically, and to be clear, statistically in his old papers in the 90s, one in particular, I don't remember the specific study, but the 0.41 was derived from, I think it was about 120 subjects. That was the average in that study.
Right.
So that was the statistically documented 0.41.
Right.
The practical, in practice, is 0.5.
Right.
In my experience, everyone's different.
Right.
0.6 might be great for one person, 0.2 for the next, 0.48. It all depends. But the reality is, when you link the Tscan to the EMG, which in my mind you shouldn't be doing definitive DTR therapy without EMG linked, and totally understand how to correct that and follow that and watch the end result, I don't think it should be performed.
Yes. Well,
So-
going even one step further, is that without use of the Tscan, you really don't have an objective recording of
Right.
that time that's involved.
Yeah.
Without using EMG, you really don't have an objective evaluation of the firing of the musculature, of the masseterial musculature.
Right, and
So, and that's tied in with only two muscle groups, with the masseter and the temporalis. What if the medial pterygoid
Which we can't put in a
or
lecture.
lateral pterygoid is also involved in this? So many of our investigative tools are not an all or nothing evaluative or of evaluation nature.
Right.
Rather, they're the best you can do at that given time.
Right. To make it even a little more complex, in my opinion, one must image the back, the joints themselves, before one initiates DTR therapy.
And I would
Or
agree
any
with that
kind of-
concept.
Any kind of irreversible.
Yeah.
And by the way, splints are irreversible. Just because you can take it out and throw it away doesn't mean it hasn't done damage if it's going to do damage.
I agree with that also.
I mean, if you build a splint in the wrong bite position, depending on what's going on with the cartilage, you can cut off vascular blood supply to the medial pole. You can cause an avascular necrosis. This is reality, and now that's kind of pushing it. That's a rarity, but it can happen. So in my mind, I don't mess with the front in a major way. In a minor way, I will, but in a major way, no, unless I've looked at the back. What do you think about that?
I quite agree. You need to look at the back, at the
joints,
the joints themselves. You have to look at the anterior, and you have to look at anything in between.
Yep.
A comment that I might make is that in addition, with our industry or with any profession, truth is in the eyes of the beholder. So if one feels that a particular type of protocol is the cat's meow that yields the greatest amount of truth,
Right.
then one defends that position. And again, with knowledge,
Based on one's experience.
right, and with our knowledge in TM, joint health, and also with occlusion, as far as the damages that occur with occlusal disease, we really should be looking to join hands rather than separate ourselves and argue that one technique is better than another. Maximizing the information and utilizing that for your treatment is key.
I agree. One of the world's experts in TM surgery and imaging, Dr. Mark Piper in Florida, he made a comment to me that I'll never forget. And I've told you this before. All the camps are right some of the time, all the camps are wrong most of the time. That's because in his world, and he's at the bottom of the funnel of hell, I call it, what I can't fix, I send to him.
Yes.
At the bottom of the funnel of hell, they've been everywhere, they've done everything, and he's found that you have to look at the back. And all these people, all these various philosophies, these camps, I'm not going to say names, you know, they're utilizing orthotics or splints, pieces of plastic that don't do anything definitive or permanent. And then they're empirically treating. They're not getting a read on where the cartilage is. The cartilage between the skull bone and the jawbone is unbelievably important.
Yes.
Relative to the entire bite.
Yeah.
So how can one correct something in the bite if the hinge itself is out of whack? It's just like a door or a jam with hinges. If it rubs too much, the hinge might be loose, and that's why it's rubbing.
Yes, and going one step further is a question on the concept of what is physiologic for a given patient and what is not.
Right.
That varies with each patient.
Big time.
So something that shows on imaging to be pathologic within a joint often is an adapted pattern which is physiologic for that individual.
Right. We shoot CTs. We've been doing that for over 3 years. MRIs, we just started recently. The MRI is the bomb. To be able to see the soft tissue definitively is amazing, and it helps us make decisions. And I can tell you that of all the modalities, you can't take any of these tools away from me. If you do, I stop doing what I'm doing.
Yeah.
Because the more I learn about all this, I can't proceed until I've, my goal is to figure out when to do it, when it's going to work, when it's not. But my point is, relative to what you said, there are times when someone looks to be in much worse shape than another, and we apply the DTR and it works. Whereas there are times where we don't have this wonderful scenario, we think it's doomsday, or my point is the opposite can happen. Looks like an easy case. It might help some, but it didn't help definitively. That's because there are oftentimes layers to the problem. It's not just always bite, and it's not just always joint. Sometimes you got cervical input. Sometimes you have sympathetic input like CRIPS, complex regional pain syndrome. All kinds of crazy things. Lyme's disease can do a number on a joint. If you're not imaging the condyle, how can you know that? And then check the history, look for Lyme's. How can you know that things are stable up in the joint? You can't. So of course, if something's unstable up here, it's all connected. It's going to alter your bite. So for someone to jump in and just do these occlusal adjustments randomly, I don't care if it's equilibration or DTR, ICAGD, whatever you're talking about, or even splint therapy, because that is an adjustment. I'm sorry, it's not reversible. You have to look, and you have to have a complete understanding of the anatomy, and you have to continue to learn. And what you said is profoundly important. Everybody should learn to get along, because the end of the game, it's not about who's right, who's wrong. It's about helping the patient that needs your help.
Right.
And that's why I do this. I enjoy doing it because we like putting together, where it's like I'm a detective. I'm trying to dissect the facts, the history, objective metrics. I'm not just touching and feeling. I'm not just, does this hurt? If it hurts, it's too late.
It's too late, right.
Oh yeah, signs precede symptoms. I mean,
right.
There's all kinds of signs of occlusal disease that most dentists will introduce. And sadly, I hate to say this live on camera, but a lot of times the dental work itself that a dentist has put in has caused part of these problems.
Well, it's estimated by a number of different well-respected professionals that iatrogenic treatment results in 80 to 90% of occlusal muscular problems, and
which is the majority of TMD pain and problems.
That's right. And likely relates to a huge percentage with TM issues if it is not a macrotraumatic injury
Right.
that caused the problem.
And we should differentiate. Microtrauma is small tap, let's think. Let's say teeth that aren't fitting right, muscle spasming because of that. Is that fair? How would you describe micro?
Microtrauma is not necessarily an evaluator for imbalance within the system. Microtrauma can be, yes, prematurities that cause occlusal disease.
The bite being high.
Right.
Right.
But also, microtrauma is a term that applies also to the aging process. So someone that shows excessive attrition on the occlusal surfaces who happens to be 90 years old,
Sure.
you expect to see evidence of attrition, whereas excessive attrition, which is present in a 20-year-old, has a totally different implication.
Of course.
That applies excessive parafunction.
Right. Grinding and clenching.
Right. So microtrauma is chronic function or parafunction over time.
Well, we haven't talked about macro trauma.
Okay, sorry.
Just real quick,
I'm
define
sorry.
macro.
Yeah, macro trauma is a sports injury. It may be an automobile injury. It could be a youngster taking a fall against a counter as they're learning to walk.
Yeah, I never know.
So many conditions of that nature. But what it is an incident of excessive force.
Imparted to the chin,
Right,
which can tear cartilage at the medial pole,
right.
specifically. And that's
Specifically
worse.
medial pole.
Right. Whereas, in contrast, micro trauma is confined to the lateral pole of the disc.
Right,
Lots of people on this planet are walking around with micro trauma and lateral poles that are torn.
Right.
Not as problematic. Those types of patients are usually amenable to occlusal adjustment therapy to help with their muscular TMD problems. However, the macro traumas and the medial poles, different world. That may or may not respond, and that's what we're trying to figure out.
right.
When we can push the envelope.
One interesting concept to explore, perhaps, is the so-called clicking of a joint.
Yeah.
The audible noise or the observance of a non-smooth opening pattern in particular the sagittal plane.
Right.
That tends to be a fallout or result from a lateral pole movement or displacement or inability to maintain its proper relationship between the eminence and the condyle.
Well, it's like this. You've got lateral pole being pulled on by lateral pterygoid. And then you have the posterior band of the lateral pole as the bone, the condyle reduces back on top of it, you get this little snap.
Right.
Because between the condylar head and the glenoid fossa, two hard substances that are made out of bone, you have this little bow tie that's thicker, and that's snap, 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 snap. That's why they're popping and clicking.
Would you agree that a medial pole injury is more likely to be not observed with that subluxing condition?
I believe you're right.
That it is more associated to pain conditions from the posterior compartment.
Well, what scares me
compression.
with medial pole, what scares me is the feeder creaks that feed the condylar head come in from the medial. When you tear a medial pole, and that pterygoid is by definition pulling it towards the medial slightly and anterior, you can constrict that blood supply.
Right.
And if you put a splint without looking at the back, for example, we talked about this earlier, if you put a splint in it, let's say centric relation or fully seated condylar position, or in this case it would be called truly non-adapted centric posture, you could, by forcing that mandible back, you're dragging that bone up higher, that disc is more likely to cut off that blood supply coming in medially. That's when you can get an AVN.
Right.
That's what I mean by, I don't care if they say it's reversible, it's not reversible. And you wouldn't do an equilibration to fully seated in that condition either. Hence the importance of imaging the backside.
Yes.
If you're ignorant to that, you shouldn't be doing this.
Right.
That's the whole point of all this. I don't care if it's DTR or equilibration or if you're restoring down and forwards, you need to know where your cartilage is.
Right. I have two questions for you, two major questions. The first question is perhaps a shorter, will institute a shorter answer.
Yeah.
But which investigative tools do you consider to be viable at this point in time? We're now in 2015. Which investigative tools do you think are of benefit for occlusal therapy, and secondly, for TM diagnosis?
Well, it's all related, regardless of what we were taught in school or what we hear in mainstream dentistry. Occlusion and TMD are intricately related. The teeth are kind of a window that we can see on the exterior to give us an idea of what's going on in the interior, being the joints. As far as tools that are absolutely important, the Tscan is probably number one, and I have to image the back. The Tscan, the EMG, the MRI, and the CT, those would be the minimal. I mean, I won't practice without it anymore, on the TM patient. And I can tell you, hundreds of people later and coming from all over the world, it's really sad because some of these fixes are simple. Some of these fixes are, the cartilage is in a great place, it's iatrogenic, a dentist introduced faulty, restorative work in space and in time.
Right.
That is the slam dunk DTR case. The trick is when the patient walks in, that's why we've implemented this about a month ago. We no longer will see a patient unless we have an MRI to perform full-blown DTR therapy.
Right. Now, what about when it comes to specifically microtrauma? Which investigative
Tscan.
tools do you think?
If I just wanted to be better as a restorative dentist, it's absolutely critical. It's cheap because, I'm a general dentist. I do lots of fillings and crowns. We do CAD-CAM, we do Sarah CAD-CAM, and it's very accurate, much more accurate than lab-made stuff.
Yep.
However, it's still not perfect. And even though I'm aware of all these crazy things and what the bite can do, every now and then I'll stick in a CEREC that's high. Mm-hmm. And the only way I can truly find it is with the Tscan.
Right.
And so every dentist on the planet, and this is not a sales pitch, I don't care if another company comes out with it. Let's call it an automobile. First there was Ford, and now there's going to be Chevy, and then Chrysler, and I don't care who comes out. The point is measure the occlusion, the way the teeth come together, how the mandible closes in space and in time, and that's the only instrument we have presently available.
Right. But are there any other tools, like for instance, I don't want to lead you on here,
Yes.
but would you consider other indices of occlusal disease?
Oh, sure.
Other tools.
Are you talking about like looking for signs?
Exactly.
Oh, of course. Yeah, that's
because TM
signs of
issues
occlusal
are
disease.
one portion of occlusal disease.
Right. That's like an end game usually,
Right.
unless you have a macro trauma event.
Yes. Right.
Oh yeah. If you're talking the simple, basic, which is the vast majority of people, you have the lateral pole tears. That didn't happen from a fall necessarily. That is most likely because of bite issue. It may not be the dentist's fault even. It might be that the kid lost a tooth or is congenitally missing, teeth behind it tipped into the space, and you've got this little thing sticking up.
Right.
The brain, central nervous system keeps feeling it, it keeps smacking at it, it's a posterior tooth, keeps ramping up the muscle to get off the back teeth, and it can't get off the back teeth.
Right.
So, oh my gosh, hypersensitivity, CDH, FDH, cervical dentinal hypersensitivity, frictional dental hypersensitivity, wear, abfractions, exposed
When you
dentin,
say wear, you mean
recession.
wear facets,
Oh yeah.
gingival recession.
Oh yeah, the wear facets, it's amazing. When you take a Tscan bite and you cross-correlate the data on the screen with the actual mouth, sure enough, there it is, this nice little shiny spot.
Yeah.
And a restorative crown or on natural tooth even, almost always invariably on second molars, which of course is closest to the hinge axis. There's less room for error. So I, as a general dentist with the knowledge I have of occlusion and TM, let's say I never want to go there. I have to respect that second molar. I could better be on my game with that second molar. And I had better be on my game with my canines. Don't
Right.
ever grind off the lingual of a canine.
Right.
Nature put that there for a reason.
Yeah.
You want the shortest way to get somebody into a serious TM pain, muscular pain problem? Start grinding on the lingual or palatal of their canines.
Yeah. Yeah.
Oh yeah, or the incisal edges. Don't
Right.
go there. If you don't understand this stuff, that's cool. If
Yeah.
you don't want to, that's great. Don't mess with the palatal of the canine ever.
Right.
So,
Well, and you very quickly mentioned before also not adjusting the incisal edges of the other anteriors.
they are players too, but the canine is primary.
Yeah, I agree also. I agree also from a clinical perspective and volumes of neurological information that come from the canine are greater than other surrounding teeth.
I believe every tooth, and this sounds hokey, it's not. I believe every tooth has a different pathway to the central nervous system.
Yep.
In my mind, it's not just back and front. I think they're each programmed to do a slightly
To
different
have
thing.
their own. Right.
I think they're little fingers. I think they're sensory organs. I know they're sensory organs.
Yeah.
I know that they communicate neuroanatomically, neurologically, however you want to put it, to the central nervous system, what's going on down here, so we don't break teeth all day long.
Right.
It's common sense. I break a tooth, it's a living organ. I introduce bacteria into my bloodstream. It doesn't lead to a fruitful life. I could die 200 plus years ago before antibiotics and what have you. Hence, it makes sense that evolutionarily speaking, we develop pathways to protect us from busting our teeth. Bottom line. So those Homo inferiors that didn't have this died off. We Homo sapiens superiors that did, we perpetuated because we had genes that coded for specific pathways to protect this part of the body that's completely exposed.
And Dr. Yiannios, I thank you for your contributions to our science. I think
I thank you,
advancement-
Dr. Coleman.
but no,
You've been in this game a lot longer than I have.
Well, no, I think the advances that you've made really help our understanding, our meaning the profession's understanding of the relationship between TM issues and occlusal issues, meaning the contact of teeth. So I think that you've dramatically improved our understanding, and I thank you.
Well, it's all about the patient. It's not about someone thumping their chest. It's not about someone being right or someone
Quite
being wrong.
agreeably.
Yeah, everybody's got something to contribute, and I'm just one guy who happens to have a penchant for videography.
Yep.
And I'm reaching out and trying to meet the right people and
Yep.
trying to figure it out because I'm curious.
Yes.
Because when I see a change that's predictable and reproducible, most of the time I wish it was 100%. I'm not going to tell you that DTR always works even in my hands. It doesn't always work because there are things out there that are different.
Yeah.
There are outliers. There's
Right.
always an outlier. Nothing's 100%.
Right.
I wish it was.
Yeah.
Maybe someday it will be.
Yep. Well, I thank you very much.
Thanks.
Thank you for the opportunity to work with you here.
Oh, of
this
course.
week. Yep.
It's been great.